Hello students, welcome to Conceptual OBG. This is a section of OBGY Nuggets, and in this section of OBGY Nuggets we try to give bits of information in very limited period of time. So today we'll be talking about RISUG, that is RISUG, Reversible Inhibition of Sperm under Guidance. Myself Dr. Avir Sarkar, faculty at Conceptual OBG. Today I'll be talking about this topic. Now, this is a very important topic considering recent advances, because you have short notes as well as you have long question or you have viva questions on recent advances. Remember, in male contraception, we at present have two established types of contraceptions. One is barrier contraception. Barrier contraception, we all know, male condom. And secondly, we have vasectomy. Okay, so vasectomy is highly effective, but vasectomy is irreversible method, whereas barrier contraception or your male condoms are reversible ones, but they are short acting and they have very high failure rate. So none of them are ideal methods of contraception, and so male contraception in India is still very much lacking. So what we do is, for an ideal male contraception, we do not have much to do with the male contraception. But Professor SK Goa from IIT New Delhi, now working in IIT Kharagpur, he had developed that ICMR funded project, the novel project, which has successfully undergone multi-centric phase 3 trials, whereby it had the potential of becoming a mass injectable male contraceptive because it is easily available. So what we are doing is, we are injecting a polymeric agent of 60 milligram of styrene maleic anhydride SMA, 60 milligrams of SMA dissolved in 120 micromoles of DMSO. DMSO is dimethyl sulfoxide. So it is 1:2 weight by volume, whereby DMSO acts as the transport medium, and the site of injection, we inject this solution into the lumen of the vas deferens. Okay, so vas deferens of the male, in that we inject the agent. Now, what is the mechanism of this agent? The main mechanism of action of this agent is occlusion effect on the vas deferens. So the moment you inject it into the vas deferens, say this is the penis, this is the urethra, on both the sides this is the prostate gland, there are seminal vesicles which are draining on it, and then it goes to the testis. These are the both the sides testis with epididymis. So the vas deferens goes there. So once you inject it into the vas deferens, it will have an occlusion effect upon the vas deferens. So it will occlude the sperms from traveling to the efferent duct and the urethra. So apart from that, it inhibits or disturbs the inherent negative electrical surface charge possessed by the sperms. So what happens is, the sperms have their spermatozoal acrosomal membranes. These are the acrosomal membranes of the sperms. So the acrosomal membranes have been disintegrated and there is rupture of the acrosomal membrane. So the spermatozoa, which are, even if some of the spermatozoa go through the occlusion effect, then also they will not have the capability of fertilizing. Okay. Moreover, the pH of the RISUG is acidic, which neutralizes the process of alkalinity of the semen. So these are the three effects by which the RISUG acts. One is the occlusion effect, the second is the neutralization of the alkalinity of the semen, and the third is it lyses the acrosomal membrane so that the sperms do not have the capability of acting or fertilizing. Okay. So pre-procedure, what we will do for the client is, with the gather approach, informed consent. These we all know. Partner consent is also taken at this moment, because till now it is not out in the market. Now dry the area with after washing it with soap and water, and ask the client to lie down in supine position in the surgical table. There is no recommendation for antibiotics at this moment. Surgical steps, what we do is, under aseptic precautions, first the scrotum and the penis is drawn away, okay, and then the painting and draping is done. Traction can also be applied so that the area of injection is identified. Now what happens, this is the penis, okay, and both the sides you have the scrotum, okay. So at the penoscrotal junction, locate the ideal entry point, which is midway between the penoscrotal junction and the upper pole of the testis. So the penoscrotal junction, from here the scrotum is starting, so penoscrotal junction and the upper pole of the testis, okay, there the midpoint of this in the midline will be the ideal entry point, okay. Anesthesia will be 2% lignocaine with epinephrine injected to make a superficial wheal of 10 to 15 mm in diameter. Then what happens, we give basal nerve block, that is nerve to vas deferens is blocked with 2 ml of local anesthetic being given in the external spermatic fascia as an injection. After that, what we do is, with the 3-finger technique, you will use a 3-finger technique, and with the 3-finger technique stabilize the vas deferens first on the right side, then on the left side. You can do first the left side also or the right side. Most of us are right-handed, so it is easy to do the right side. So we'll stabilize it, and a superficial puncture is made which is widened to 2 mm, and then what we will do is bring the vas deferens out of the this scrotal skin and then inject the RISUG. So the RISUG is injected, and after, once you are injecting the RISUG, you should remember that the retrograde flow into the testis is not there, so that you pinch the retrograde part of the vas deferens. Once you have injected it, wait for 2 to 3 minutes and then let the vas deferens go back. Okay, similarly do it on the other side also. So the injection of the solution will help to maintain the occlusion. Okay, so after it is done, then what we do is antiseptic cleaning is done, no suture is required, and a band-aid is applied with tape over the puncture site, and you observe the client for 1 hour. 1 hour observation is enough. Advise abstinence for the next 3 days, and that is enough. Remember, husband semen analysis is not required like vasectomy. In vasectomy, we require husband semen analysis to be done, and azoospermia has to be documented. But here azoospermia is not needed. Even if there is a little bit of sperm in the semen, that sperm will not have the fertilizing capacity. So till now, it has been done in 600 subjects, and all subjects have reported very good compliance with no side effects even after 6 years of injection. So a long follow-up of 6 years has already been taken. The method of reversal will be very high dose, that is 200 to 500 micromoles. Mind you, 120 micromoles was the solvent. Now if you are using 200 to 500 micromoles of DMSO, it will dissolve the agent and then it will be extruded through the urethra. Secondly, you can inject 5% sodium bicarbonate also. This will also help in reversal. It will be injected at the same place of the vas deferens and it will extrude the RISUG from the urethra. So this has a very significant advantage because high contraceptive efficacy of 97.9% with only 2.1% of failure rate, and it is easily reversible one. It is a male method of LARC, long-acting reversible contraception, and no effect on the hormonal profile, no impairment of sexual pleasure, no discomfort of the female partner, quick return of fertility with reversal, and it is a method of LARC. So I hope this has been a good video whereby it will give a ray of hope for male contraception, because it being a method of LARC will be taken up by the male counterparts because most of them do not want vasectomy. So stay tuned to our channel, and these OBGY nugget videos will be very helpful because in short time you can gain a lot of information. Thank you.